We have Dr. Matt Tennant, who's going to be speaking to you about emerging treatments in AMD. He's an ophthalmologist with Alberta Retina Consultants and associate clinical professor at the Department of Ophthalmology at U of A. His research interests focus on many forms of retinal disease, including complex retinal detachments and macular disease. Dr. Tennant is part of the team grant that we mentioned at the outset with Dr. Ian MacDonald on the new clinical trial, that the gene therapy clinical trial in choroideremia, and he's going to be performing the surgeries that Dr. MacDonald described. So without further ado, Dr. Matt Tennant.
So Dr. Grieve, I think, has been talking about the treatment of macular degeneration. I'm going to be talking about emerging treatments, new treatments that are coming forward, some very soon, others down the road. And so I'm not sure if Dr. Grieve talked about macular degeneration itself. I think just a background about what is macular degeneration perhaps would be helpful to people. And so macular degeneration is the most common cause of vision loss in North America. And so it's particularly prevalent in people of Northern European ancestry. And so if your ancestors come from anywhere in Northern Europe, like myself, you will be most likely affected by macular degeneration. And, of course, there's two types. There's the dry kind, which is more common, and the wet kind, which is less common. Unfortunately, even with the dry kind, although it's perhaps not as severe as wet macular degeneration, you can certainly lose vision, and significant vision. And the trouble for all people with macular degeneration is that it affects the central part of the vision. And so your visual acuity for driving, reading, recognizing faces is affected, whereas your peripheral vision in most cases is good, hopefully for the rest of your life, which is great. But the key to date anyway has been to try to first preserve vision, but second to improve visual acuity. And to date, this has not been successful with dry macular degeneration. Now, for wet macular degeneration, of course, it has been more successful in terms of people in this room may have been receiving injections of Lucentis or Avastin into the eye for wet macular degeneration. We don't really have that option for dry macular degeneration as of yet. There's no known benefit to injection of anti-VEGF for dry macular degeneration. So when we talk about dry macular degeneration, there's genetic factors. So we talked about if you're from Northern Europe, your ancestors are. That's the big one. Age. So unfortunately, the older you go, the more likely you are to have macular degeneration. And so if you live till you're 95, it's pretty sure you're going to have macular degeneration. Yes, particularly if you're from Northern European ancestry, and then if it runs in your family. So if someone in your family has macular degeneration, it's very likely. So my grandmother, she's passed away now, but she had macular degeneration, wet macular degeneration in both eyes. And so it's very likely that unless they come up with better treatments, that I'm going to develop dry macular degeneration and then down the road develop wet macular degeneration. So lifestyle modification has some impact. And so we can't do anything about how long we live. Hopefully live a long time. We can't do anything about our genetics in terms of where we're from, where our ancestors are from, and what our genetic makeup is. And so if you happen to have those risk factors that are going to lead to macular degeneration, that's your lot. So how do we treat it? And so lifetime modification. So sunglasses, somewhat helpful, but not a big deal. Wearing sunglasses in the sun is great. Not smoking. So in the past, many more people smoked, but nowadays not that many people smoke. Smoking increases your risk significantly of progression of dry macular degeneration and also progression to wet macular degeneration. So you never want to smoke. Exercise. So providing appropriate weight, exercising on a daily basis. These are all helpful for reducing the risk of progression. And then vitamins. So the AREDS study, I'm not sure if it was mentioned today, but so AREDS2 was a study looking at vitamins A, C, E, copper, and zinc. And so AREDS vitamins, Vitalux, Ocuvite, no-name AREDS brands, all of which provide vitamins to reduce the risk of progression. This reduction in risk is not great. It's a 25% reduction. So what that means is that if you have no macular degeneration, not really going to help you, but if you have intermediate dry macular degeneration, so you have changes in keeping with dry macular degeneration, it reduces the risk by about 25% of going on to develop wet macular degeneration or what's called geographic atrophy. Geographic atrophy is a thinning of the retina in the back of the eye, and it leads to central loss of vision. And so that's, when we talk about dry macular degeneration, the worst kind of dry macular degeneration you get is geographic atrophy, thinning of the retina in the center. And then, or you could go on to develop wet macular degeneration. So that's AREDS1 is vitamins, and now there's an AREDS2, which is currently underway. AREDS2 is a few additional vitamins in addition to the ACE, copper, and zinc. And so there's lutein and zeaxanthine. And so lutein and zeaxanthine are both vitamins. They're antioxidants. They're found in vegetables like red peppers or yellow peppers. And lutein and zeaxanthine are felt to be helpful. And this has been, in the past, has been shown through various studies that are studies where people look at diet. So if you go to a population and you look at what people eat and then you assess whether they have macular degeneration, it found that there's a trend for those people who take lutein and zeaxanthine, eat a lot of red peppers, let's say, then they have less risk of developing macular degeneration or progression of macular degeneration. And so this is being looked at in a pill form. And then omega-3. So omega-3 is found in fish oils. It actually comes from krill, and actually originally comes from algae. So if animals that eat algae in the ocean, they pick up this omega-3, and then fish eat these small animals, and then we pick it up in the oils of fish. So omega-3 is also being looked at. And then the other thing that's in AREDS1, in Vitalux or Ocuvite, zinc is about 80 milligrams, which is quite a high dosage of zinc and can cause stomach upset. And so in the new formulation, it's 25 milligrams. And the hope is that it is just as good as the high-dose vitamins, but doesn't cause the same stomach upset. And then vitamin A. So vitamin A can increase your risk of lung cancer if you're a smoker. And so for those people who are ex-smokers or current smokers, they can't take vitamin A in a supplement. And so AREDS Vitamins has high-dose vitamin A, and so they have to take a special formulation called AREDS or Vitalux S, let's say, if it's a Novartis product. So for smokers, and it doesn't have the vitamin A component. So the AREDS2 is looking at the same thing to see whether or not the vitamin A is actually of any benefit. Because it turns out there's some research nowadays that certain people who have problems with their eyes may actually be and macular degeneration may have a problem with how vitamin A is digested or broken down. And so there is some thought that actually holding back vitamin A may be beneficial, and extra vitamin A may not be beneficial. And so one of the research trials which was done was with a pill for dry macular degeneration to see whether this pill called fenretinide would benefit people with dry macular degeneration. And so when we talk about macular degeneration and progression, we talk about this thing called geographic atrophy, the thinning of the retina. And you can actually measure how big this spot of thinned retina is found. And so over time you can measure, like in 2 years, how much has it grown. And so when you're doing a study, it's a nice endpoint to look at how big an area of geographic you start with, and then 2 years down the road, look at that same area, and has it changed? Has it gotten smaller, bigger, or has it stayed the same? And the natural progression is these areas tend to grow with time. So over 2 years, it should grow. And so if you take a pill and it stops that growth, well, you feel that the pill has been beneficial. So fenretinide was a pill to look at this. Unfortunately, to date, the research has not been helpful in terms of it didn't show much benefit. And so this pill, fenretinide, was hoped to be beneficial. It stopped vitamin A breakdown, and it was hoped that it would stop geographic atrophy. It didn't work. So that was a pill. There's another couple of pills that are being tried, all of which are to do with the metabolism of the retina. None of the pills to date have been shown to stop macular degeneration. And so there's a variety of studies looking at this. They're enrolling patients, but no one to date has shown that macular degeneration can be stopped by taking a pill. The other research that's being done is injections of medication into the eye. So macular degeneration is felt to have some inflammatory components. What that means is people who have, let's say, arthritis. If you have rheumatoid arthritis, that's an inflammation of a joint. If you get an infection, that's an inflammation. So if you cut yourself, you get a red mark on your skin, that's inflammation. Your body responds to inflammation by trying to stop if there's an infection or stop a breakdown of a tissue. And it's felt that macular degeneration is a breakdown of tissue at the back of the eye, and so there's an inflammatory component. And so if you can reduce inflammation, let's say, by doing an injection to the eye, you might be able to stop or at least slow macular degeneration. And so there's a variety of studies right now that are enrolling patients looking at injections of anti-inflammatory medication to see whether it'll slow macular degeneration. Once again, to date, there are no results that have shown benefit. So there's hope. There's some results that are coming forward, but to date, nothing that's been shown to be beneficial. The next thing is stem cells. So, we hear a lot about stem cells in the media and in the newspaper, let's say. And so what are stem cells? So the cells that are involved with macular degeneration are the retinal pigment epithelium. They live underneath the retina. They provide nutrition to the photoreceptors of the retina. And retinal pigment epithelial cells are lost or die as part of macular degeneration. And so when you have no retinal pigment epithelial cells in your center part of the vision, that's called geographic atrophy. That's the end point of dry macular degeneration. And so if there was a way that we could stop the loss of those cells or bring them back through stem cell research, then this would be great, because those cells are the ones that provide nutrition to the photoreceptors. We all see with our photoreceptors. If you lose the retinal pigment epithelium, you no longer have nutrition for photoreceptors. The photoreceptors eventually die as well. And so stem cell research is being done where stem cell RPE cells, retinal pigment epithelial cells, are injected underneath the retina. And these studies are in the early stages. They're being done out of California. And when you do trials, you do a safety trial first to make sure it's not more harmful than good. And so you don't even actually look to see whether there's benefit, but you look to see whether it causes harm. So I think about 12 patients have been injected with this medication, which is a stem cell. It's a baby RPE cells, which then grows into an RPE cell and is injected underneath the retina. And then over time, the question is going to be, do they work like retinal pigment epithelial cells? Do they provide the same benefit as your normal retinal pigment epithelial cells? Do they cause problems? Things like, do they stop growing on their own? Do they continue to grow? I mean, if they continue to grow, that would be a problem. And so the first stage has been successful in terms of it was felt to be safe. So those cells were injected, didn't cause any problems. So the second phase is to see whether they're helpful. Do they help the vision? And so there's a few centers across the United States, Wills Eye Hospital, where I trained, Bascom Palmer in Florida, a couple of other places where this is currently enrolling patients. So patients are being enrolled, and they have macular degeneration with geographic atrophy or advanced dry macular degeneration, and they're being injected with these stem cells. And we're going to know probably by 2014 whether this has been beneficial. And they're injecting, let's say, 50,000 cells, 100,000 cells, 200,000 cells to see, what's the right dosage of these cells, how many need to be injected to provide the best outcome. So that's hopeful, although it is surgery, and so it's a pretty big deal to have surgery and have cells injected underneath your retina. And so there's significant risks of complications. The ultimate risk would be blindness if something was to go wrong. And but it is hopeful. It's good for macular degeneration, this research, and then also for something called Stargardt's disease, which is a hereditary retinopathy, which is similar to macular degeneration. And once again, these patients may benefit by retinal pigment epithelium cells that work properly. The other thing that's being done, to date, there has been there has not been a mechanism yet to replace photoreceptors. And so photoreceptors are nerve tissue. It's like your brain. We don't, to date, have any way to use stem cells to replace those photoreceptors, but a lot of work is being done. The primary research right now is on retinal pigment epithelial cells, that if we can save those, then maybe the photoreceptors won't die. But to date, we have not been able to replace the photoreceptors. There is a guy in Canada. He was in Halifax. Now he's out in Victoria. what he's trying to do is he's trying to make cells that are not photoreceptors work like photoreceptors. So what that means is that how it works is that you have photoreceptors, they send a signal, they get light, they see the light, they send a signal to something called bipolar cells, which then attaches to a nerve that runs to your brain. So how you see is that the light activates the photoreceptor, and then a signal is sent through the bipolar cell to the brain. So if you don't have any photoreceptors anymore, there might be a way to change the bipolar cell so it can see. And so if you can make it light sensitive, so if you can make a bipolar cell be able to see light with a variety of different ways, then it's in the same location or very close to where the photoreceptor was, and it might be possible to allow that to see. And it wouldn't be the same as a photoreceptor, but it might be near as good in terms of there's not as many bipolar cells as photoreceptors, so your vision wouldn't be as accurate or acute. It wouldn't be as sensitive, but you'd still be able to perhaps see to get around. So that is taking place right now, but not in humans, but in animals, and so this offers a hope for the future in terms of trying to figure out a way to work if your photoreceptors are gone to still have an ability to see. Other research which is being done, which is pretty exciting, is actually an electronic chip. And so there's this thing called Second Sight, AREDS2, and what it is a complex device. It's actually a camera which is on a pair of glasses, and it's a video camera, and that video camera sends a signal to a chip which has been implanted into the retina. And so if you think about your retina, it's a thin film like the film on a camera. And so what they do is they implant this chip underneath the retina or in front of the retina, depending on how you're going to have things done. But it's very close to where the retina is, and it can send a signal to the retina bypassing the photoreceptors. And so in the same way that this doctor in Victoria is working on this problem, with the bipolar cells, this doctor or these people what they're doing is they're electronically replacing the photoreceptors and sending a signal to the nerves so that then the signal goes to the brain and you can see again. But it's a pretty complicated device in terms of, first you need a camera on the video on the glasses, which isn't too big of a deal, but then it actually sends a little signal wirelessly to a device which is surrounding your eye. So you've had eye surgery and you get a band, like a belt around your eye, which has a little power source, a little battery. And then from that belt is a device which is actually inserted into your eye. So you have surgery, you have wires that run from the outside of your eye to the inside of your eye. And then it sends signals to this little chip that sits at the back of the retina. So you might imagine a lot of things can go wrong if you have such a thing, particularly infection. I mean, you have a place where bacteria could travel through these wires or along the wires from outside your eye into your eye, and that would be catastrophic. But there are some people in the United States and in Germany who have had this implant. They've had it for a number of years and are able to see. Now, the chip itself is pretty rudimentary in terms of you don't see color, you see light, and it's a grid. So let's say you see a 16 by 16 grid of light. So you can recognize shapes, but it would be difficult for you to get around and difficult to see properly. And so that offers potential. These are for people not really who have macular degeneration, though, because you think of macular degeneration, your vision actually, apart from your central vision, it's awesome. Your peripheral vision is really good. Well, this is not going to be anywhere near as good as that. And so people who have macular degeneration who want to regain their central vision, the technology to provide a chip which is as accurate as your current ability to see is years in the future. And it is unlikely in the near future for chip technology to benefit people who have macular degeneration. In the past, let's say 5 years ago, surgery was done in an attempt to restore vision for people with macular degeneration by rotating the retina, by moving the center part of your vision to another part where the retinal pigment epithelium was better. That was not successful in terms of, first, there was lots of problems with double vision because your eye had been rotated, and so it wasn't lined up properly anymore. So you had to have multiple surgeries to realign your eye. But then also it turned out that it just wasn't very good, and the side effects or downsides were so great. Other people are currently actually cutting the retinal pigment epithelium from another location in the retina, doing surgery, and then inserting it underneath the central part where you're missing your retinal pigment epithelium. Once again, very high risk and not too much benefit. All these things are potential possibilities for the future, but unfortunately, to date, apart from vitamin therapy, which most people who have macular degeneration will already be on, we do not have better treatments, unfortunately.
No, I was just going to ask you a question. When you get wet macular degeneration, you obviously still have the effects of dry. Is that correct?
That is correct. So that's a very good point, because we can treat wet macular degeneration and we can preserve vision from wet macular degeneration, but we still have no ability to stop the gradual progression of dry macular degeneration. And so patients will be disappointed because I will have dried up the retina and yet their vision continues to worsen. Now, it's a slower progression, but unfortunately it does tend to progress. You are quite correct.
I have the end-stage wet macular degeneration for a couple of years.
Both eyes?
Both eyes. I lost my central vision, and I would like to know if that injection will help me, or if this stem cell that I have been researching will help a patient like me.
It's a very good question, and so I guess there's three components to that. First, when you have wet macular degeneration, what happens with time is, in many cases, not in all cases, but in many cases, you'll have bleeding at the back of the eye, which will lead to scar tissue generation. And the scar tissue is underneath the retina, and if you have it in both eyes, your central vision is impacted. And so scar tissue, surgically, we don't have a way to remove it. If we remove it, unfortunately, the retina comes with it because it's built into the retina, and so we would cause further damage. And so surgically, we cannot remove that scar tissue to date. There's no medication or other treatment that we know of that can cause a scar tissue to dissolve or be removed without further damage. Stem cells don't have an ability to remove the scar tissue either as of yet. And then your question as to whether injections would be helpful. So many people who have scar tissue also have some fluid leakage at the back of the eye. And so as an example, for me as an ophthalmologist, what I'll do is I'll see a patient who has scarring of both maculas. And let's say they hadn't seen someone before, I would do an optical coherence tomography test, which is a sophisticated test to see whether or not there's any fluid leakage at the back of the eye. And if I saw fluid, the injections work for fluid. They dry up fluid. And so I would have a talk with the person to say, you have scar tissue. I can't remove that scar tissue. I don't have an ability to do that. But I do have a way to get rid of leakage. And sometimes as the leakage goes away, the vision can improve. And so I would offer a person that possibility, with the understanding, though, that it's unlikely to make a big difference. And so let's say in early wet macular degeneration, I can have a chance to improve things 30, 40, 50%. In this situation, maybe 10 or 20%, the possibility of improving it. And so I don't know if you've ever received injections to your eyes, but you should be seen by a retina specialist and have that test and see if there is associated leakage. Because if there is, sometimes by removing the leakage, then the vision can improve somewhat, because the leakage itself inhibits function of the retina. And so not only do you have scar tissue, but if you also have leakage, then if I can remove that leakage, perhaps I can improve the function without actually removing the scar tissue. Now, what's interesting about scar tissue is over time the body does tend to shrink it somewhat. So if it's inactive, the blind spot can sometimes shrink a little bit, and your function can improve, first because you're getting used to the problem and so you're working around it using your peripheral vision, but also because the scar tissue tends to shrink a little bit over time, and so thereby sometimes you notice an improvement in your vision. So I don't know how long you've had your problem for, but those are things that I would recommend.
Also, I have followed up one. It's called the implantation of a television for advanced macular degeneration, and it's already been approved in the U.S. But the problem was, when I called them, they said it's only available in the U.S. and only 75 years and older. And I'm only 67, and I still want to see my grandkids grow up.
So are you talking about, I didn't talk about this, I should have. Are you talking about a magnifying lens or a television lens?
No, it's a television that they implant on the eye, but I'm not sure whether it applies only to dry or wet.
Yeah, so that may be the AREDS2 that you're talking about. And so what it is, it's not a television implanted, but it's a video monitor or a video camera, which is on a pair of glasses, and then there's a chip that's put at the back of the eye.
No, they implant the television. It's a small chip that they put right inside the eye.
Yeah, so you're right that the chip is inside the eye. Yeah, and it's connected to a camera that sees. But so your vision, I can promise you right now, your vision is way better than any camera that can be put in your eye right now. Even though it's really bad, let's say, I don't know how your vision is, but your peripheral vision is 100 times better than any technology that could be inserted into your eye at the moment. Those technologies are good for people who have no vision, as in they can't see light. That's the people that's helpful, or very limited hand motion vision. But if you're able to see to get around a room, your vision is way better than what's possible right now through technology.
Yeah, because I think my acuity is 20/400.
Yeah, so that's exceptionally good compared to what would be possible with any kind of electronic device to date.
Okay, thank you so much.
No problem. Thanks for your question.
My question is, I know that you're going to be doing the surgical work on Dr. Ian McDonald's, that trial. Mm-hmm. Can you describe exactly what you're going to do and whether or not you think it'll have any applications for AMD or other therapies in the future?
Yeah, sure. So it's a surgical treatment. It's what's called a virus vector. What that means is a virus which is being changed by people to have a DNA component which is helpful, will be injected underneath the retina of people with something called choroideremia. So choroideremia is a genetic eye disease which leads to loss of the retinal pigment epithelium and the cells underneath the choroid. And so it has a genetic defect which leads to misproduction of an enzyme, which means that these cells die. The retinal pigment epithelial cells die when you're much younger than it would otherwise. So people with macular degeneration, RPE cells die, let's say, when you're 65 in the center in people with advanced dry macular degeneration. Well, this happens when you're a teenager, or maybe you're 10 and your RPE is already starting to die. And so what my job is going to be the technician to do surgery on the eye, remove the vitreous, which is the jelly that fills the back of the eye, and then inject a medication, which is this virus, underneath the retina. And we do that for patients actually with macular degeneration right now, not the virus component, but we do the same surgery for people who have bleeding underneath the retina. So sometimes if you have a bad bleed or blood under the retina with macular degeneration, which can occur with wet macular degeneration, sometimes we inject something called TPA, which is a clot-busting medication that breaks up the clot, and we inject that under the retina. So the surgical component, we do this for other things. Not too complicated, but somewhat fine work in that the needle has to go into the right location. And so what happens then is once we've injected the viral vector underneath the retina, then the virus goes into every cell and replaces the defective DNA with DNA that works. And so it's pretty spectacular. It actually replaces the genetic defect in the retinal pigment epithelial cells, thereby hopefully allowing them to function normally. Now, the early studies are going to be in patients who already have fairly advanced choroideremia, and so it's unlikely to make a big difference, but the first study will be a safety trial to make sure it doesn't cause any harm. But then the second phase would be to do this in young kids. So kids that we know have choroideremia are going to lose their vision without treatment, and if you can treat them before the retinal pigment epithelial cells are lost, then maybe we can stop it in its tracks on a permanent basis. And this kind of work has already been done with something called Leber's congenital amaurosis, which is a genetic defect which leads to early blindness when you're first born, or by the age of 1, you're totally blind. Because the photoreceptors no longer work on a permanent basis. And so you can imagine how devastating that would be. And so there's already been 48 patients, I think, to date who have had the virus for Leber's, fixing that particular DNA defect, injected under the retina, and it's been safe and been very successful in terms of in the little area that they've done the injection, those photoreceptors have started to work again, and patients have been able to see, to get around a maze more effectively than if they had not had the treatment. And so pretty spectacular results, which appear to be long-standing in terms of once you've had it done once, wherever it's been injected, it seems to have fixed the DNA on a permanent basis, at least over a 4-year period to date. And it is possible that for patients with macular degeneration that this is a potential possibility for the future. And so dry macular degeneration is a genetic disease. It's multifactorial and it's age-related, but it is really to do with your DNA. For whatever reason, for a variety of reasons, the DNA is not working properly and you're gradually losing your retinal pigment epithelium. So that's a DNA, you could fix that problem. So if you could find exactly what DNA defects each person with macular degeneration has and then arrange a fix with a virus and perhaps even help people when they're younger, you already know your DNA, when you're first born. And so you could figure out these risk factors and then do treatment prior to even ever developing macular degeneration. And so that offers hope for the future for younger people anyway.
Hi. You said that virus that you inject in that one area, and you said that that's been helpful. Can you do multiple areas? Can you do more than one injection?
Yeah, so you certainly could, although to date it's because it's early days. They were worried that it was going to cause harm or might cause harm. They injected just one small area, and they didn't actually even inject into the center part of the vision because of the risk of harm. So they injected it to one side. And so, for sure, the next stage of the trial would be injecting more virus, lifting the retina up more aggressively, and probably doing multiple injections. And so it is pretty unbelievable if you can think that we can fix the DNA on a permanent basis for that individual. Now, it doesn't help their kids because their kids are going to have the problem still, but it does offer that potential. And so the trial results mean it's going to be coming up pretty soon, actually, the 4 or 5 year results, and then they're going to be going into a larger phase trial where many more patients would benefit. The trouble is that you need to know exactly what the DNA defect is, and only certain DNA defects can be fixed in this way because of the size. If you need small defects, if you have a big defect which needs a lot of DNA, it can't fit in the virus, and so it doesn't work. And so only a certain subgroup of people benefit. And so Leber's, congenital amaurosis, which is very rare, has about 12 different genetic defects. And so only 2 groups in that 12 genetic defects actually benefit from the treatment. The rest, to date, it hasn't been helpful to them. So it's a very targeted approach. And so choroideremia is another disease which has a fairly focused DNA defect, which is fixable. Macular degeneration has multiple different DNA defects. And so it would probably, you'd have to approach it with multiple viruses perhaps, or multiple different fixes. And so it's a potential possibility, but not to date. Dr. Greaves is going to ask me a very hard question.
Who cuts your hair?
Well, that's a funny story. You know the story.
No, Matt, I want to ask you about because you're injecting a virus under the retina that has the DNA in it. Is there any issues or concerns with the body mounting a response to fight it, like an immune response?
Yeah, for sure. And so it's interesting in that I just learned this morning. Like I'm literally the technician for this procedure. I'm not the brains. And so luckily Dr. McDonald is the brains of the operation. And so Dr. McDonald is a geneticist and an ophthalmologist, and so he's the lead on the project. But we were talking this morning about it, and the virus that they use, the reason they use that particular virus is its affinity to the retinal pigment epithelium. And so for some reason, it likes the retinal pigment epithelium, and it doesn't want to go anywhere else. And the cells that were in, so we put a little pocket of fluid adjacent to these cells. The photoreceptors are up above, the retinal pigment epithelium is down below. It likes these specific cells, and these cells don't tend to proliferate and don't tend to go anywhere else. And so if, on the other hand, you were to inject it and it got into a white blood cell and it liked a white blood cell and it was multiplying, then that could certainly cause problems because you would have now changed the DNA on all these cells that are traveling throughout the body, and your body would most likely fight it as an infection, a viral infection. But because it likes to be only in these certain kinds of cells, and that's why you use this particular vector and virus, then it doesn't seem to cause any problems. But, of course, that's the risk. And so long term, we don't know. We don't know what happens in 5 years, 10 years. And those are all potential side effects that could be catastrophic, and you'd go from a situation where you've helped someone's vision, but you've killed them, literally. And that has happened in the past with stem cell research and things. And so we have to be very careful. And it's frustrating for people because you want a solution now, but at the same time, it's very easy to be too quick to do something and further damage them. Yeah, thanks for the question.